Welcome to the Inspired Hygiene Podcast. I'm your host, Rachel Wall. I'm an RDH and founder of Inspired Hygiene. For over 20 years, we've had the unique opportunity to see what really happens inside thousands of dental hygiene ops and what it takes to create transformational change that impacts the lives of patients, practice owners, and teams. Each season, we'll focus on one powerful topic, breaking it down with practical strategies, real stories, and tools you can use right away. Let's get into it. Hello, everyone, and welcome back. This is season 2 of the Inspired Hygiene Podcast. And today we are going to talk about a topic that dentists and hygienists know well, but that we don't talk about a whole lot, and that is periodontal maintenance. And this is a really important topic because very often it is one of those things that as hygienists, we just kind of check the box. Okay, this is the procedure that we did. But what we see at Inspired Hygiene, having the opportunity to kind of look behind the curtain at a lot of these procedures and in the charts of a lot of patients, we see that it often is an area where patients kind of fall through the cracks. And so today we're going to talk about periodontal maintenance. We're going to talk about stable or slipping from a perspective of patient health, but also from a perspective of practice health. And really, what does that mean? How you can take a closer look at this procedure and create some distinctions about this procedure, and also look at your practice in this particular area and see where this might be periodontal maintenance might be hiding some other areas that would be in your best interest to work on. All right. So, periodontal maintenance is not about just checking the box. This patient has had scaling and replaning in the past or periodontal surgery or whatever it is. So they need to be on periodontal maintenance. It really is about protecting the healing that you have worked so hard to achieve with your patients and catching relapse at a very, very early state. So I have a bunch of notes for this episode because I want to get this right. This is really important, and there's a lot of science behind this as well. So I just want to make sure I hit all of these points with you today. Okay, so first, let's talk about the slip. Is your Perio program slipping? And then we're going to go into more detail on the periodontal maintenance. And I want to bring this up because it's related to your periodontal maintenance count. So I would say probably 80% of the dental practice owners that we speak to about coaching, probably 80% of them at the time that they come to us, their periodontal percentage as calculated by Inspired Hygiene. Every consulting company has a slightly different formula for how they calculate perio percentage, but the way we calculate it, 80% of them are showing up and their perio percentage is below 20%. Now, if you've listened to any of these podcast episodes, you might be aware that the benchmark is at least 35% of, we have a formula that is Prophy's, perio maintenance, and scaling and root planing. We put them into a little formula, and about 35% of that should be perio related. That should be your perio percentage. And if you want to find out what your practice perio percentage is, or even your own personal perio percentage, we're going to have a link in the show notes to our perio percentage calculator tool. And you can also find it on our website, inspiredhygiene.com. Just scroll down. You'll be able to find that on our main page. And I encourage you to do that. Just kind of see where you stand. So if 35% is the benchmark and 80% of practices show up at less than 20%, then it's very obvious that they have a lot of room to grow and opportunities to expand their periodontal program, their periodontal diagnosis and treatment protocols. Now, there's another 20% that come to us and their perio percentage is over 20%. And sometimes they say, hey, I think we're doing pretty good in perio, but we wanted to talk to you because our hygiene production has flatlined and we're not sure what else to do. Or we've really struggled with trying to find a hygienist and we've heard that you help teams with that. And so we want to talk to you about that. Or, I was meeting with my dental CPA, and we've seen that this is one area of the practice that really hasn't grown in the last 5 years. And I have some ideas about that. But they just want to talk. But when they see, and honestly, for myself too, if I see that their perio percentage is over 20%, I think, okay, well, they've done something to work on this at some point. And so here's what typically this looks like when we see a client show up and they're over 20% perio, but they know something is not right, they're missing something, is typically they have done some work on their perio protocol in the past. So it's very common that they'll say, yeah, we actually worked with a consultant about 10 years ago. We really had a great perio program going. And then we had some changes in our hygiene team. And some of it has stayed in place, but it's just not, our hygienists aren't consistent anymore. And we really need to revisit that and tighten that up again. Or they will just say, we refer out most of our active therapy to a periodontist, which, by the way, the vast majority of time when teams say that, when I then ask them, okay, how many patients per month are you referring? It ends up being, oh, we refer like maybe 4, 5, 6 patients a year. So they're really not referring that many patients, which means a lot of that active disease just is not being it's not being treated appropriately. Let's say that. It doesn't mean it's not being treated at all. It's not being treated appropriately. But let's go back to these practices that maybe they worked on their perio protocol in the past. Maybe they had a hygienist that was really proactive with periodontal diagnosis and treatment planning, and that hygienist left for whatever reason. But they're still keeping these patients in perio maintenance, right? And for those practices that have done a great job of, once patient goes into scaling root planning, they put them in perio maintenance and then they stay there for the life of the patient. Like, congrats. That alone is a great accomplishment. You've established some value. You have kind of drawn a line in the sand that this is, where this patient needs to be. But here's where I will challenge that is, if we really dig deep into that periodontal percentage and we pull out the amount of scaling and root planning patients compared to the number of recare patients, typically that active scaling root planning is very, very low. And those practices where they're over 20%, very often it's being carried by periodontal maintenance. And here's how you can tell. If you run your numbers for like the last 6 months and then take all those numbers, so run your number of quads of scaling root planning, your number of quads of perio maintenance, your number of quads of prophy, and you take all those, divide them by 6 so you can see the average number of those procedures per month. And then look at the comparison of scaling root planning to perio maintenance. If you see that you have 100 patients per month in perio maintenance and you have 12 patients per month in scaling root planning, then there's one of your signs that perio maintenance is carrying your perio percentage and that your active therapy is very low, right? And in that same example, if you had 12 quads of scaling root planning per month, that's probably 5, let's see, 3 to 5 patients per month that are going through active therapy. And so if you look at that as a percentage of all of your patients in recare, very often you will see that it's a very, very low number. So when you run your periodontal percentage, look at the number, take that. It's a great benchmark. It's something to look at, but then dive a little bit deeper. And we do this very deeply in our Hygiene Growth Roadmap service. It's a deep dive hygiene assessment. It really helps practices see like what are they doing really well in hygiene and where do they have opportunities to grow and tighten things up and expand their services. So look at that, not only from the percentage, but look at how many patients are actually going through active therapy per month and compare that to 2 things. Number 1, compare it to the number of comp exams you have on average per month. If your number of comprehensive exams, whether it's a comp exam or a comprehensive perio exam, let's say that is 50 per month, and you're seeing 48 quads of scaling root planning per month on average, then your hygiene team is probably doing a pretty good job of getting new patients into therapy. I would say look real closely at existing patients because there's likely an opportunity there. The other thing I would do is look at the total average number of recare patients. So if you're seeing 400 recare patients every month into your practice and you're only seeing 12 quads of scaling root planning, right? That's 3 to 5 patients. There's a huge opportunity to level up your perio diagnosis. So a little bit of math there, but that's just a little glimpse into, is your perio program stable or is it slipping? And I wanted just to address that and the role of periodontal maintenance in your perio percentage. So now let's talk about periodontal maintenance, um, and what really the goal is. What is periodontal maintenance? What are some of the misconceptions, and what are some of the mindsets around periodontal maintenance? I will say that the mindset that I come across a lot with hygienists is, I'm not sure it's any different than a pro fee. I'm doing the same thing that I'm doing in a pro fee. The fee is higher, but I don't really know what I should be doing that's different than what's in a pro fee, because I want to be thorough in both of those procedures. I don't really know what I should be doing that's different in a periodontal maintenance. And sometimes I wonder if my patients notice that there's no difference. And I would say that patients typically don't have a point of reference on that unless they have just gone from a pro fee into perio maintenance recently, right? And they see the same. Or maybe they have a spouse, right, that's receiving a pro fee and they're receiving periodontal maintenance, and they're saying, well, yeah, she did that for me too. Yep, she did that for me too. She did that for me too. So then what's the difference, right? So then they start to question that. So first and foremost, dental team members, regardless of your role, and clinical leaders, like, you must have a clear differentiation of a pro fee and periodontal maintenance, and what are things that happen in a periodontal maintenance that do not happen in a pro fee. And let's go through a couple of those. So one of the very basic standards in a hygiene department is, how often are we evaluating and recording our patient's periodontal health parameters, right? So bleeding, pocket depths, recession, furcation, mobility, suppuration, all of those things. How often are we assessing that clinically? And then how often are we fully recording that, all of those points? And I would say it's not that common in our experience. And we've looked at hundreds and hundreds of practices, even just over the last few years. It is very uncommon that practices are consistently recording all of those parameters at least once a year. Now, it's real common that practices are recording pocket depths, but you could have a 4 millimeter pocket depth and the tissue could be pink and firm and not bleeding and there's no inflammation. Or you could have a 4 or 5 millimeter pocket depth and it is there's active bone loss happening, and there are signs of attachment loss, and there's signs of active inflammation. But if that is not documented, how are you ever going to know? So the core standard is that at least once a year, every one of your patients should have a complete periodontal evaluation, and all of those points be recorded. Okay, that is the very basic standard. With periodontal maintenance, you may do that at every visit. That may be one of your differentiators. Or perhaps at once a year with periodontal maintenance patients, you record all those parameters. And on the other visits, you record what we call a periodic periodontal evaluation, which is pocket depths and bleeding. And I would say for periodontal maintenance, that is the minimum standard. Once a year, complete full recording of all of those parameters. And every other time of periodontal maintenance, we're doing a periodic periodontal evaluation and recording. So we're recording pocket depths and bleeding. Okay. Those are very basic standards. So take a look at that. Where does that differ with a pro fee versus periodontal maintenance? The other thing I think that's helpful is if we really talk about the purpose and the goals of periodontal maintenance, and really what is it? So the maintenance phase is the primary role of the maintenance phase, right? When patients are in periodontal maintenance, is to maintain the healing and stability that has been achieved with active periodontal therapy. Now, active periodontal therapy can be surgical or non-surgical. Okay. And this matches with Carranza's clinical periodontology and implantology textbook. I'm a nerd. I buy textbooks every few years. I use them as reference because I believe we need to have credible sources. In addition to a consultant's viewpoint, we need to have credible clinical sources that are backing up those recommendations. Okay. So their definition, the way that Carranza describes it, is that maintenance therapy helps preserve tissue homeostasis and prevent further loss, right? Further loss of periodontium. Okay. That regular reevaluation allows us to detect any type of recurrence of disease or relapse of disease at an early stage. And it is important for us to be very vigilant in periodontal maintenance, right? We're not just checking the box. We are actually doing what the point of periodontal maintenance is, which is we are very carefully evaluating, is this patient stable, stably healthy, or are they slipping back into active disease? And I will say that term stable is something that we need to be really careful with, and we'll talk about that in just a minute. So that role of this close monitoring is to really track the periodontium's health or disease and just not assuming that things are stable, right? We're really assuming, we're looking for, okay, is there breakdown? We're really on guard and we are on high alert with these patients. And again, it has to be something that's different between a periodontal maintenance and a prophy. With that being said, of us being really diligent and detecting that relapse early, these are 4 reasons why periodontal maintenance patients are much more vulnerable to relapse. Okay, number 1, they have the same genetic, immunologic, and microbiome factors that were at play when they developed this disease, right? Their genetics are not going to change. So if they have a genetic predisposition to periodontal disease, then when they were diagnosed with active disease, they have the same genetic predisposition today. So that means they are vulnerable to relapse. The AAP said in a paper in the early 2000s that 50% of the variation between periodontal progression, right? My periodontal progression versus yours is based on genetics. Okay. So they have the same genetic predisposition. Number 2, they have a fragile epithelial attachment. Remember, when we're doing non-surgical therapy and we are seeing pocket depth reduction, it comes because of 1, reduction in swelling, right, from that inflamed tissue healing. And 2, from the apex up is those new junctional epithelial fibers, right, creating a new junctional epithelial attachment. But those are not connective tissue attachments like they were when we had healthy tissue. These are epithelial attachments, and they are much more vulnerable and they are much more susceptible to microbial attack and continued loss. Okay. So they are in a vulnerable state. That healing, it creates that attachment, but it's much less robust than that connective tissue attachment. Second is their home care and lifestyle. Now, many patients will do better, right, when they're going through active therapy or they're really recent after that active therapy and they've seen some healing. Many times they will revert back to old behaviors. Either they will stop flossing, they will stop using their power brush, maybe they quit smoking for a little while and now they're back to that, or they're just generally not taking great care of themselves. So you've got to look at those lifestyle factors too. And then the last one is new or worsening systemic or medical conditions, right? If they have diabetes, how are they doing managing their diabetes? They are forever going to be vulnerable to active periodontal disease if they have diabetes, if they have other autoimmune conditions that make them more susceptible to inflammation. There are even genetic factors, we talked about that can be tested for, that can show that patients have an exaggerated response to inflammation. And think back to these patients too. When these patients are being diagnosed, right? Ideally, you're also giving them a stage and a grade of the disease. Now, remember, the grade is how likely this is to respond to treatment and how likely is this disease to progress, right? How rapid is it going to progress? If this is a patient that you remember or you look back in the notes and you say, oh yeah, I remember this patient, they really didn't have that much plaque and they're not showing up with that much plaque at perio maintenance, but they still have bleeding and they had a lot of inflammation, that is a huge red flag for you. Okay. These are not the patients that you want to extend their intervals just because they don't have a lot of plaque. If they still have bleeding, they are not stable, they are slipping. And so these are the patients that you really want to keep on a tight interval. You might even have them on less than a 3-month interval, right? And really the only time that we're extending that interval, ideally from a clinical standpoint, is when we are truly seeing that they're in a state of health. Now, so let's look at this paper. You're going to see a link to this in the show notes, but this is a paper that was written in the 2017 World Workshop when the AAP and the EFP got together to create staging and grading. And this is something that we teach from a lot. And so what you're going to see as you review this abstract is essentially, and in this introduction is a practical definition of periodontal health would be a state free from inflammatory periodontal disease. This in turn means that absence of inflammation associated with gingivitis or periodontitis, as assessed clinically, is a prerequisite for defining periodontal health, meaning we can't say that this patient is healthy unless they have an absence of inflammation. Okay, so how many periodontal maintenance patients that you see have an absence of inflammation? And if they do, great, then the periodontal maintenance is working. And what they're doing at home is working. Okay. But when we say stable, what is our intention by that? Are we saying they are stably diseased? They are stably inflamed, meaning their inflammation is chronic and it's staying the same. It's not getting any better, but it's not getting any worse. But remember, if they have active inflammation, they are still carrying that inflammatory burden, which puts them at an increased risk for heart attack, stroke, type 2 diabetes, and all other kinds of inflammatory complications. Okay, so those are 4 things that are really important and why patients are vulnerable, patients that have been through periodontal treatment before and periodontal maintenance. Genetic predisposition, fragile epithelial attachment, their home care and lifestyle, and new or worsening systemic problems. Okay. So the other thing that happens to us a lot of times when we say the patient is stable is a condition I've talked about, and we'll put a link to this in the show notes as well. I talked about this with Kirk Barrett of Act Dental, is called bleeding blindness, right? And it's when clinicians get so used to seeing bleeding or familiar problem sites, and we begin to normalize them. Like, this is just normal for this patient. And again, labeling them as stable, even when they represent ongoing disease, is not helpful for the patients. And a lot of times what happens is the hygienist is trying to address this in periodontal maintenance, and very often it is extending beyond the treatment that is needed is extending beyond what's appropriate in periodontal maintenance. We'll talk about that in a minute. And that incremental loss, if it's not addressed, right, it can progress quickly, and something could happen with the patient that we don't know about from a systemic level. And let's say, they have a health event and now it's 6 months before they come back, and all of a sudden, oh my gosh, we've lost a lot of ground. So bleeding and pocketing in these same zones, or I should say deepening pocket depth measurements, attachment loss in these same zones should not be expected. Like, those should be red flags. One thing I would encourage y'all to do, and if you set this up with the team and say, you know what, we've committed to this, but sometimes we need some outside eyes. You see the same patients over and over again, and they, again, we normalize it, is do some audits. Maybe have your periodontal maintenance patient see another hygienist, just for that, cross-reference, or do some audits and say, hey, I noticed that, audit each other's charts. These 3 patients that you saw last week, they actually have had this bleeding, every time for the last 4 visits. So next time you see them, that's going to be something to really pay attention to. The other thing that I will point out too is it's real easy and tempting to copy the periodontal charting data from one visit to the next. And I will say that when I see exactly the same numbers for 2, 3, 4 visits in a row on a comparison chart, then I think we probably didn't look very closely. So pay attention to that too. All right, let's talk about what is periodontal maintenance from a CDT coding perspective. And so let's see, I'm going to read this from Practice Booster. Practice Booster is a fantastic insurance advisory tool, and they have the ability to publish the ADA's CDT codes and give tons of explanation and just narrative around these codes. But what periodontal maintenance is, it says this procedure is instituted following periodontal therapy and continues at varying intervals determined by the clinical evaluation of the dentist for the life of the dentition or any implant replacements. So the intervals do not have to be 3 months. You could have a patient that has had periodontal therapy in the past. They are healthy. They have a healthy, healthy but reduced periodontium, and they could be on 4 or 6 month intervals if they have no bleeding and they're maintaining just fine, but they're still periodontal maintenance because they have those factors that we just covered. The other factor I will say out of that, and speaks to that fragile attachment, is sometimes patients have residual pocket depths, right? And it's difficult for them to access those. So that's another reason why periodontal maintenance is so important, because you're accessing those areas that they can't get to. That might be a little deeper than with a prophy patient. So periodontal maintenance includes removal of the bacterial plaque and calculus from supragingival and subgingival regions, site-specific scaling root planing where indicated, and polishing the teeth. If new or recurring periodontal disease appears, additional diagnostic and treatment procedures must be considered. So one thing I want to point out is that it says it includes site-specific scaling root planing. That's not included in a prophy. So this is a benefit to these patients that are in perio maintenance. If you see, hey, this area is relapsing, you can do some site-specific scaling root planing, and it's included in the fee of the periodontal maintenance to a certain point. Now, this CDT descriptor does not give you any specific point, like number of sites to where you need to move them back into periodotherapy. At Inspired Hygiene, we suggest if you see more than 2 to 3 sites where there's active inflammation going on, then you must consider additional diagnostic and treatment procedures. Also, it doesn't say scaling root planing procedures. You might say, hey, we're going to utilize a site of local antibiotics in this area. That would be doing something. That would be additional treatment procedures. We're going to recommend to this patient something like Perio Protect or Perio DT, or we're going to recommend Sonicare and Oracare. We're going to recommend some other treatment procedures or services to help resolve this inflammation. That's the whole point, right? Is that you're tracking, you're being very vigilant and diligent with your evaluation and what you're recommending to these periodontal maintenance patients. So that's a really important part of that descriptor, and your documentation of that perio maintenance must reflect what you actually did, including any sites that you did scaling root planing on, changes in probing depth, bleeding. You want to make sure all of that is documented in the perio chart and in your notes, because if an insurance company ever comes back and says, hey, they need to have had scaling root planing to qualify for ongoing periodontal maintenance, then you can show that actually we did that in the periodontal maintenance, and hopefully that would fulfill that requirement. But that's a little tip that I learned from some of my insurance specialist friends. Also, all payers are going to require a complete periodontal charting, radiographs, all that diagnostic data to qualify and validate that 4910 claim. So keep that in mind. And just doing a supragingival cleanup does not really justify 4910. If you're doing localized scaling and root planing, then you need to call it what it is, right? And patients don't ever go from a prophy into periodontal maintenance without some type of periodontal surgical or non-surgical treatment in between there. So what I want to say in wrap up is, again, it really is about being vigilant, being precise in our evaluation, and really paying attention to these periodontal maintenance patients. The risks that the disease created once are still there. And our job is to really be proactive guardians of their health, not just their oral health, but their overall health. So I'll leave you with this challenge. Look at the last 20 periodontal maintenance patients that you saw. How many had persistent bleeding anywhere in their mouth, particularly in the same zones? How many were documented as stable when maybe if you look at it a little bit closer, they actually have active disease and inflammation that should be addressed? And what are you going to do differently at that next appointment? Maybe look even forward into your charts of patients that are coming in and be prepared for how you can address that, more thoroughly the next time and really set that apart. Are there things that you want to add to periodontal maintenance to really make it stand out? And I'll tell you, a lot of times it's communication. Patients don't know how well we take care of them unless we tell them. So, I always love to go back and pull that perio chart from when they were diagnosed, when they had that first non-surgical or surgical treatment, and then how do they look today? You know what? When you started this journey, you had 42 sites of bleeding. That's an extreme amount of inflammation. And today you had 2. And we are really paying attention to those, and how can we get that down to 0? Show them how far they've come. Show them the value of periodontal maintenance. Remind them that the reason you're doing so well is because you're staying on this interval, and we're really paying this close and detailed attention. So thank you all so much for being with me on this episode. What you could do if you get value out of these is if you could just please share this with a colleague, share it with a teammate. We'd love it if you could leave a review. Just give us some insight on what you'd like to hear, how this is really resonating with you. And just thank you so much for listening to the Inspired Hygiene podcast. Until next time. Thank you so much for listening to this episode of the Inspired Hygiene podcast. We hope you got a ton of value and some things that you can really take away and implement now. So as always, we invite you, if we can help you in any way to optimize your hygiene department, head on over to inspiredhygiene.com. And as always, stay inspired.